anybody that takes advantage of those academic life and EM modules, right, for which you get a lot of asynchronous, well, this is the man that brought that to us. So, welcome back, Dr. Grock, and we are definitely in the
It fills with so much like warm, gooey nostalgia for being here. It started this morning actually when I got on the train and it said 2-5 service to Flatbush, which was running with delays. I got a little worried, but I got here on time to quickly grab pastrami, egg, and cheese and then run here. Sorry for being merely on time. And I think it's a little sad that I don't know all you guys. You know, I spent so much time here, and when you're here, you meet 8 years worth of people. You meet everyone above you and below you. I only had you few straggling seniors. But in a way, I know all of you. All right, well, let's get into it. Today I'll be talking about this thing. So where's interns? Raise your hands. What's this thing? Atelectasis, exactly. So this is me, class of 2015. We were so young then, right, 2 years ago. And I would be remiss if I didn't mention, and I know some of you guys don't want to hear this because you feel like you're underappreciated, overworked, and underpaid, and to some degree you are all three. But I have done a decent amount of academics since I left here, and I do a lot of online stuff, which brings me in contact with a lot of other people. And I will say that the education team here is bar none better than any place I've ever heard. So it's very hard when you're, like I said, feeling overworked, underpaid, and unappreciated to be thankful. But you guys are extremely lucky to be here. And I hope at some point you realize it, hopefully before you go. But this place is very special to me, and I miss some of the people that trained me oh so dearly. And while I would maybe not prefer to be recognition, I remember very fondly. I hope you do as well. All right, so let's get started. We're going to do a group activity. It's going to be a personal group activity. I want you guys to think about the last patient, maybe 2 patients you saw with chest pain. And in 30 seconds, I want you to replay that history in your head. Think about what facts you got, what questions you asked. And I want you to think, did you do a complete job? So you got a little timer there, 30 seconds. Get to it. All right. Who here thinks 100% complete job, best you could have done? So I feel like, yeah.
I do, but I'm on outside.
Fair enough. But it's hard in the ER to do this, right? We all want to, and we all want to take good care of our patients, but it's really hard to do. And we don't need a full 30 seconds for this, but yell out what you guys did on your physical exam for that last patient, 2, 3 patients, or what your standard is for patients with chest pain. Yell it out. Yeah, okay. So you're going to palpate their abdomen. What other physical exam things do you do? What systems do you examine? Oh my God. Go start. Listen to the heart. Listen to the lungs. Palpate the abdomen. JVD. Pulses. Ooh, pulses.
Radio pulses.
Interesting. Did you really do pulses? Or are you saying that because of our first slide picture? I don't answer that.
Neurological.
Yeah, so so we'll talk about a case. This is my first year out of residency. I saw a 50, 60-something-year-old lady. History of hypertension, and she was a nurse in a cardiology clinic. So I know some of our patients, who here's gotten the bad feeling wave, and that's all they can get, right? This is not that patient. I walk in, I say, why are you here today? She said, I was running to my car because I was late. So I had, this is her words, I had exertional chest pain. It was squeezing, it radiated to my back. I got diaphoretic. It lasted 30 minutes. It was the worst feeling of my life, and I thought I was going to die. I asked her about risk factors. She had none. I asked her about toxic habits. She had none. I asked her about family history. She had none. I walk out of the room, and this is, by the way, like a Google image of cardiology chair. This is not what the guy looked like. Potentially Scott, I think, in a few years. Anyway, I see this guy, and he says, I know her. I want to trope it in EKG. If those are abnormal, call me. If they're not, admit her to my service. I'm cathing her tomorrow. So I had a pretty easy setup for anchoring for premature closure. Maybe a little part of me was rebelling and being told what to do by this guy with a mustache, and I kind of wanted to stick it to him. But we got the test back, and guess what? Normal, normal, normal. And I sat down and I thought about it, and I was like, look, this lady doesn't really seem like ACS. She doesn't really have the ACS risk factors. The pain radiated her back, and then I believed that she had pain. And I was hoping this case because she gave me all of the facts of that history that I did not always and do not always ask. She gave them to me. Exertional chest pain radiating to the back. She said those words. And I bought that she was in pain. I know we get some people that are like, I'm here for chest pain. And you're like, oh yeah, what happened? And they're like, 3 days ago, it just came and went. And you're like, we'll do some tests, but you're fine, right? This is a lady that you believe something bad happened to her. Something bad happened with a totally normal EKG and a normal trope. And I actually thought back to something good old Dr. D'Souza harped on me about, which I think is a good kind of trick for anchoring, is let's say you think it's disease X, and you do a pretty good test for disease X, and it's normal. It is very dangerous to then say, well then this person is fine and I'm sending them home, right? What you need to do is take a step back, think about other diagnoses that you didn't consider before, widen that differential and see what you can do. I went back and talked to her and she's like, nope, shot straight to my back, sudden onset, exertional chest pain. And I was like, I gotta get this lady. And we did, and she had a dissection. And the other thing that helped me on this, right, is how often do you think of dissection in people that you have, the people that present with chest pain that you see? I think I lost my grammar there. I might as well just speak Spanish. Right, you don't think of it that often. Like, how many people are you guys scanning for dissection? The other dangerous thing about this was the hospital is that did not have cardiovascular surgery. So if that lady got admitted and crumped, that's kind of it for her. Now, I'm not telling the story to be, oh, I'm so smart. I'm telling you the story because I got very lucky. Not only did she give me all the pertinent facts, not only was I a little maybe irritated with this cardiology chief, but ACEP had just come out with their new clinical guidelines on dissection, and it was reviewed on MRAP. And being a good learner, I didn't just listen to MRAP and say, oh, some more people said this, I'm going to put it in practice. I read the stuff. You all got to do. Scott Weingart said this is okay. It's not an acceptable medical decision-making tool. Do not write that in your note. But dissection was all on my mind. I had listened to this within the last month. And I thought very long and hard about how many of these I could have missed, how many of my histories potentially were incomplete, and what I can do to do a better job for my patients. So we all know dissection, but when you read the stats, it scares the pants off you, right? So 75% mortality rate in 2 weeks. The 1 to 3% mortality an hour always makes me laugh, because I always think, like, well, in 48 hours, they have like a 140% chance of being dead. And then this is under ideal conditions. Every doctor does everything right. Every nurse does everything right, which I know standard Kings County, 27% of people die with an aortic dissection. So this is a can't miss diagnosis. Not only for our patients, but if you guys are worried about lawsuits, which is a whole other lecture for the day, but I think it's of importance to note when they look at lawsuits, right? 33 cases of dissection that sued, 30 of them dead, and 3 of them paralyzed. So this is a disease where if you miss it, it seems like the results can be terrifying. And the other cases, in 21 of those 33, failure to diagnose or delay in diagnosis. So whose job is that, right? That's our job in the ER. And this is a little bit dangerous. Now, do we have any med students here? I know it's URAS season. No med students? Ooh, weird. All right, interns, you're getting picked on again. Back when you guys had your short white coats, and someone presents with chest pain, what are the 5 to 7-ish things that can kill them? Yell them out. Can't hear you. Tamponade. Pericarditis, myocarditis, tamponade. PE. Tension pneumo.
MI.
Yeah. ACS, MI, dissection. There are a couple silly ones. 4 Hobbs, pneumonia, right? Those are the 7 things, right? When you guys were med students, you knew that, right? Anyone? Yeah, you guys knew that. So I'm attending now. I work with residents. And I've done this before, but it makes me giggle, right? I sit down on my computer after we have a 10-minute conversation on all the dangerous things that we've clinically ruled out on a patient, and this is their note. Right? That's not appropriate. Those 7 things that can kill someone, that's your medical decision making. If you don't test for it, you need to write something in your medical decision making. All right, and we're going to kind of get back to this in a minute. But my first hurdle of the day, especially for my case, is every patient will start with chest pain. That presents, you need to consider thoracic aortic dissection. Think about it. Have it on your differential in a very real way. All right. So on your history and physical, let's get into what you can do to better diagnose this disease. For starters, I learned this when I was a med student. It makes me laugh because you think about what you do when you're like a drowning third-year resident and you're tired and you're trying to be efficient and the patients keep coming. Who here does this? O, P, Q, R, S, T, U, V. I don't think there's a W. I think that's it. Right? But this is how we're supposed to take histories. This is hard to do every time. And the insurance company does, don't get me started on billing or healthcare in America, but you gotta have 4 modifying factors to get a level 5. Any patient needs to do chest pain is level 5. I know at downstate, do you guys bill at Kings County yet? Oh yeah. That was, when I was a resident here, it was like, we're gonna start billing soon. And I was like, we're gonna start billing soon. But when you get out, this is actually going to be a thing, right? There will be non-anonymized lists of your names and how many average RVUs you have that people are going to see. You will have meetings with your chairs if you are not charting well enough, and depending on where you work, the money you bring home may grossly depend on how much you bill. And the chest pain person is a level 5 chart. You need 4 modifiers. Who here does 4 modifiers on every chest pain patient every time? Hard to do. Something I want to inspire you to go for. Now, how does this come into play, right? Is there literature to support taking a good history? That sounds funny to say. There is. So they took a population of people with aortic dissections. They reviewed the notes. 42% of cases asked about all 3, quality, intensity, and radiation. 58% did not. Now, how did the diagnosis of aortic dissection go? Right? So if you asked all 3, they diagnosed over 90% of the people that presented with aortic dissection. If you did not ask all 3, 0, 1, or 2, that dropped to 50%. So I don't really know the statistics on this, but it seems like you're almost twice as likely to diagnose an aortic dissection if someone has it by asking 3 simple questions. Radiation, intensity, and quality of the pain. Now looking at the literature, it didn't come up in this study, 2 other things to think about is the pain migrating. Chest pain that migrates to the belly, chest pain that migrates to the back, and also onset. What does the subarachnoid hemorrhage present with? What's the onset?
Sudden.
Yeah, sudden onset, thunderclap. So aortic dissection tends to present very similarly, and if you don't ask, you may miss the diagnosis. There's also some past medical and social and surgical and family history that we're supposed to ask about. There's these predisposing factors. The one that actually really weirds me out is like recent aortic manipulation. I don't know what you're thinking about, so it's on there. And I actually never thought of this before researching this talk, but that kind of means calf. So if someone gets calf and they get a stent placed, and then they have chest pain, I've never thought of that potentially being a dissection, but that technically is a risk factor for an iatrogenic dissection. All right. What about the exam? So you guys mentioned this. I did not usually do this before this talk. But you listen to the heart, you get a murmur. I now, in every patient with chest pain, I will check pulses. In true Kings County fashion, I usually check it while the patient is talking so that it doesn't seem to waste time, right? You guys still, this came up in one of my interviews where they're like, oh, you worked at Kings County, that place is crazy. I was like, yeah, but you learn to be efficient. Like, during your history, you place a line and you draw the labs. Then you bill the patient to x-ray. Then you sit down and you order and you send it. In about 10 minutes, you call the lab to tell them those labs have been sent. What's your name? Where do they need to? And I do a brief neuro exam, right? I don't always do face, but I do arms and legs. And I also will ask about weakness in numbness, which is not something I used to do. So that brings us to this. This is how I love practicing medicine now. I think that this is the best way of thinking about it. Who here loves the Fagan numerator? Yeah, love it. So there's a couple things I want to point out here. One, you're going to take your clinical gestalt, and that's going to form a pretest probability. You can do a test or not do a test, depending on what that is, and you get a post-test probability. If you do not do this correctly, you are not going to get there correctly. And this is what I'm stressing on your guys' histories and physicals. The other thing I want to point out is, who knows the upper and lower limits of your pre and post-test probability of disease here? Is it 0 and 100? No. It's 0.1 and 99.9, right? Even when you decide not to do a test, you are saying the pre-test probability of disease is so low that it is below your testing threshold. You can say risks of the test, false positive, false negatives, there's all sorts of ways to word it, but that's what you're saying. You are not saying that this person does not have X. Does that make sense? And I think that this is really valuable to think about when you're interpreting test results, and also to help you not prematurely close your differential. So, question.
Can you take us through that?
Oof. Where's Adam Mauricio when you need us? Yeah. Well, long story short, you will calculate in your head a pretest probability of the patient having disease. Mathematically. We don't always say 42.8%, but you do it. You're going to do a test that has an intrinsic value, a likelihood ratio. And that graph will then tell you the post-test probability of disease. This graph comes up a lot with PE. I think it's less commonly used in other diagnoses, but I find it very valuable.
I can confidently say in 2 weeks you will learn more about this.
It's as if
we're going to do it in India much.
It's as if we planned this all along. All right. So these are some of the guidelines that talk about risk factors for dissection. And I kind of put with giant arrows the things that we've already talked about. But the thing that terrifies me is, like, I think of some of the shoddy histories that I did, and I think, oh, this guy goes home, he has a dissection, it's a misdiagnosis, and that happens, right? If I look at this chart, how many of these did I do, right? Bugs me to know when I do a better job. So I want to make sure that you're all aware of learning rule number 2, right? Every patient with chest pain, I now ask about predisposing factors. My acronym is quorum, and if you can come up with a better one, let me know. That Q is hard to fit in there. But quality, onset, radiation, intensity, and migration. And then I do a pulse and neuro exam on all my patients with chest pain now, and I obviously document it. All right. So the other way to think about aortic dissection is the chest pain plus rule. If someone has chest pain plus another characteristic, they may have dissection. So one is neurodeficit, so that occurs 5% of the time. And those can be super variable. We're going to get to that in a minute. Chest pain and abdominal pain. And this one, that scares me a little bit. 5% of cases, in this one retrospective article, 5% have abdominal pain alone. That's scary. Chest pain and back pain, chest pain and pulse deficit, chest x-ray findings. Who here at one point was a med student? Who here was asked to describe the 9 chest x-ray findings that are concerning for an aortic dissection? Anyone else remember memorizing this? Just me and Jimmy? How many of you remember that now? How many of you are waiting for radiology reads before discharging a patient with chest pain? How many radiologists are aware of these 9 factors and are going to be reliable in directing them? Right? So this is a thing that's kind of tricky. But chest x-ray findings concerning for a dissection, you always think of wide mediastinum is the main one. Chest pain plus that, probably need to do a CTA. Ultrasound. This one's kind of tricky, but it's like all things in ultrasound. If you see it, it's there. If you don't see it, you have no idea, and you shouldn't use it as part of your medical decision making to rule something out. But there is evidence. Who here does a TTE on their patients with chest pain that they're concerned about? It's kind of becoming very in vogue. Take a look at your aortic root. It gets extra tricky because if you try to look at what implies a dilated aortic root, there's no universally agreed upon definition. But theoretically, it should be less than 3 to 4 centimeters. So if it's bigger than that, start thinking about dissection. The other thing that they use ultrasound for is to look for aortic regurg or aortic insufficiency. Both are concerning for dissection. For different reasons. I don't know how much pathophys you want. Just know that those are worrisome. Those are worrisome for aortic dissection. Lastly, predisposing factors, aka syphilis, which I hear is on the rise. And then chest pain and syncope, 10 to 15%. This is not syncope, this is chest pain plus syncope. Don't get me started on like stupid European peasant. You guys know that one? This is off topic. talk to someone smart before you put it into practice. This is it out. All right. Neurodeficits are all over the place. Okay? You can have strokes, you can have spinal ischemia, you can have coma, you can have ischemic neuropathy. You can also have this peripheral nerve compression. So I have given up trying to memorize the different ways that, oh, this neuro, blah, blah. And I just think chest pain plus neurodeficit, be concerned for aortic dissection. So that's the chest pain plus 1 rule. That's one way to think about how to diagnose it. Now, is there an easier way? Yes and no. So there's a big study, and they found all the stuff that you already know, right? Severe, abrupt, ripping, or tearing pain, it radiates to the back, a pulse or blood pressure difference, and lastly, mediastinal or aortic knob winding on X-ray. So we're ER docs, right? So we are a rule-out animal. We care about ruling things out. How does this help ruling things out? The statistics are a little tricky because there's no randomized controlled trials. Aortic dissection is rare, and these are all retrospective. But what they found when they looked at this was if you had all 3, guess what? You had an aortic dissection. If you had 0 of 3 in a population with aortic dissection, or sorry, to rephrase, in a population with aortic dissection, 7% of them had 0 out of 3. So if you do all of those things, you're going to be better than if you didn't, but those are maybe not the best rule-out tests. So the AHA came along, and theirs is a bit more complicated. And they looked at a similar population. If you had 0 criteria, 4.3% of those people with aortic dissection had 0%. Maybe not quite good enough as well. And this is mirrored in our ACEP clinical guidelines, right? Learning parole, next one, there's no clinical decision rule. There's no heart, there's no perk, there's no wells. You're on your own for this one. So I tend to be more silly than I should be. But it's a lecture, it's early morning. I am wildly entertained by chief complaints. I'm wildly entertained by a lot of things. But chief complaints in the computer have always made me laugh hilariously, especially at 3 in the morning. And some of these you may notice the background. These aren't quadrumen. So this is the first one, very long chief complaint, and I circled the key part. Came to the ED. My wife is stressing me out. That one made me laugh a lot. This one is a little blurry, but I get to read it to you, which makes me laugh a lot. Patient states he's very hungry and needs a lot of food. I told this guy, I appreciate your honesty, you get 2 sandwiches. But the thing that makes me laugh to no end, do you guys see this guy's ESI? 4, right? I was trying to figure out, like, how much food do you need to need more hospital resources in the file. But that made me laugh. All right.
To get food in Class A is a lot of research.
That's true. All right. So we're going to do a brief summary of kind of the first half of this lecture. Consider thoracic aortic dissection, or you are going to miss it for every patient with at least chest pain. Ask about predisposing factors, quorum, and do a pulse and neurocheck. A couple ways to think about diagnosing it: the chest pain plus 1 rule, and keep in mind there's no clinical decision rule. So you're on your own for this one. So let's move on to the next step, right? You've done your history, you've done your physical. What do you do next? You do tests, right? So do tests help? Who here thinks an EKG can rule in or rule out an aortic dissection, right? So similar, 31% of people with aortic dissection have a normal EKG when they come in. Of those 69% that have normal EKG, they're all over the place.